everyone. Thank you for coming. I know most of you, but for those of you who don't know, I'm Madeline Boccuzzi. I'm a second-year Master's of Science student at MSc-GH, and I was very fortunate to do my fieldwork in Laos this summer, where I worked with the WHO to evaluate Laos's HIV and malaria supply chain. So this is an overview of my research. And at any point, if you have any questions, just stop and ask me. I'm going to be going through some of the stuff kind of quickly, and I'm happy to answer any questions that might not make sense. So just to give you a little bit of an idea of what I'm going to be talking about today, I'm going to give you a little bit of overview about Laos and what the country context is. So what the health system is, like what the HIV and malaria situations are like, and the role that the Global Fund has played in country. I'm also going to give you a little bit of a very quick background about public health supply chains and why it's important to be studying them and why this research is relevant. And then I'll go into my study design and methodology, show you some of my results, and then we'll go through the suggestions that will be given to the Ministry of Health. So, sorry, I'm getting used to the clicker. So a little bit about Laos. It's a landlocked country in Southeast Asia. It shares borders with 5 other countries. Thailand to the west and Vietnam to the east are its largest borders. And then Myanmar, Burma, China, and China share borders to the north, and Cambodia to the south. This whole region is called the Greater Mekong region, and is really an up-and-coming area in Asia. So there's a lot of work being done there now, and a lot of development that's occurring in the area. The population of Laos is pretty small. It's 6.2 million, and the entire country is about the size of Utah. So we're looking at a small population and a small landmass. About 32% of the population lives in urban areas, so it's still predominantly a rural population, and poverty really continues to have a rural face. That said, the country is considered a lower middle income country, and it's had really rapid GDP growth. So for the past 5 years, it's averaged right around 8%, which is pretty good for how poorly it was developed previously. It has a communist government, and the way that the government was described to me was a communist government with a capitalistic heart, which I thought was a really telling way to describe what's happening in Laos. There's a ton of development that's happening now. And one of the main reasons that there are so many development projects is because the government's 1A goal is to lose the least developed country status. So they want to graduate from that status by 2020. And they're intending to do that by allowing these huge development projects. In the north of Laos, it's a lot of land clearing for wood that they sent to China. And in the south of Laos, it's a lot of hydro dams for power. And actually, there was just an article that came out yesterday called Laos, the Battery of Southeast Asia, talking about the huge economic and environmental impacts that these dams can have. So it's a really sort of important and pertinent issue to be thinking about. So the health system in Laos is dominated by the public health system that is operated through the Ministry of Health, and there's 4 administrative levels: the national level, the provincial level, the district level, and the health center level. And there's also this sort of vague program called the Village Health Volunteer Program. And it's very loosely integrated into the Ministry of Health programming, but they are used by sort of anyone and everyone who's doing programming at the village level. So this gray entity, they're called a gray entity because it's not really clear exactly how they fit into the greater health system, but they're so valuable and they're so vulnerable, frankly, to all the different programming that comes throughout Laos. And these are 2, a district hospital and a village health center that I visited as part of my research. So HIV in Laos has actually been a relatively contained epidemic. The prevalence rate right now is 0.3% for 15 to 49-year-olds. And UNAIDS estimates that there's about 8,500 people living with HIV in the country. That number is from 2009, so it's gone up a little bit since then, but it's still a pretty low prevalence rate. The epidemic is spread primarily by 3 populations: female sex workers, men who have sex with men, and injectable drug users. And those are really the populations that the HIV program has been targeting. The program is very vertical. It's not well integrated into the health system. And treatment prevention and testing services are not available below the district health level, but all of those services are available for free. And lastly, the Ministry of Health implements HIV programming through the Center for AIDS, for HIV, AIDS, and STIs, and so henceforth I will call them CHAS to create that mouthful. Malaria in Laos is a little bit more complicated. It continues to be a really prominent public health threat, and about 60% of the country, it's endemic throughout the whole country, but about 60% of the country is really at risk at any given time. Outbreaks are really unpredictable. They usually follow the rainy season, which is between late May and October, but it's not always as predictable as that. Epidemiological patterns have shifted quite a bit over the past decade, which has been really promising. In 2000, there were about 40,000 cases reported, and in 2011, it was less than 4,000. So obviously a really positive trend. However, in 2012, we've seen a really dramatic outbreak, and we've seen a threefold increase in malaria rates just through May 2012. So you can see that's very early still into the malaria season, and that has been attributed to two things: a delay in bed net distribution, which is obviously quite relevant to my topic with supply chain management, and land clearing activities for the Namkong 2 and 3 hydro dams in Adapal province. So it's, again, it's this fine balance between health issues, environmental issues, development issues, that's all intersecting. And the Center for Malaria, Parasitology and Entomology operating program, and I will call them CIPBE going forward. Oops. So, delay in bed nets. I was able to visit the Medical Logistics Warehouse Center, which is the national warehouse in Vientiane capital. And this picture was taken on July 11th, so well into the malaria rainy season. And these are all bags of long-lasting pesticide-treated bed nets that are sitting in the warehouse, not with patients who actually need them. So this is a very clear example of a supply chain issue that has direct negative health outcomes, because these are obviously not helping people in the areas that need it most. I was sort of scolded, I would say, by CIPBE when I was in Laos, because I gave this presentation the last week I was there, and they made it very, very clear to me that the bed nets are now being distributed. So they are now in the process of getting to the people who need them. But at the time, mid-July, they were still sitting in a warehouse. Ooh, sorry, I'm not good at the clicker. So the Global Fund has had an immense role in HIV, malaria, and TB programs. I'm not going to be talking about TB because I didn't look at them, but they have been credited with many of the positive health outcomes that have happened in Laos. So that huge epidemiological shift in malaria, that is largely accredited to the Global Fund, and access to HIV treatment and care has also been expanded significantly. They are performance-based funding, so what that means is each country has to apply to the Global Fund for funding, and then the Global Fund will rate that country with a grade, and that will come up again later when we get to the results. And it's a very, very complex organizational structure. I'll walk you through it on the next slide. But shockingly, funding is actually sufficient. Funding is not a problem in Laos, which is a very rare problem. You never really hear that that's the case. In a lot of these developing country programs, you always hear that money is the issue and they always need more and more money. And fortunately for Laos, that's not an issue. So they have a little bit more leverage to do things and to make changes because they have the financing to do so. Interestingly, the Global Fund is now placing really large emphasis on monitoring and evaluation and supply chain management, and that is Global Fund-wide, so not just for Laos. But it's a really interesting development that is very pertinent to what I'm looking at. And they've developed a mechanism called the voluntary pool procurement. And it is intended for countries that either have really low commodity demands or have very low capacity to do procurement, and Laos certainly fits into both of those categories. So they did not start out in this VPP mechanism, but they were mandated to enter it in 2009.
What's pooled in the pool procurement?
So it's many countries will apply for commodities through this mechanism. So they procure, instead of just procuring for Laos or just for Tanzania, they apply for every country that's part of it, and they can get much cheaper rates through pharmaceuticals.
Regional?
It's not regional. VPP is Global Fund-wide. Countries can opt into it, or they're sort of, it's not as voluntary as it might seem by the name. So countries that have infrastructure to do procurement and can do it on their own don't have to be part of VPP. Countries that aren't able to do it are strongly encouraged to enter VPP. And VPP has benefits because you can sort of take that whole responsibility out of your pool of things that you have to do. So for Laos, with a very limited human resource capacity, it helps to have someone do it for you, but then there's obviously sustainability issues. We'll talk about that more. So I said the Global Fund is very complicated. And I'm just going to give you sort of a quick and dirty overview of how it works, because it is important to keep this in mind as we're going through a lot of the results that I found. So the country portfolio manager sits in Geneva at the Global Fund Secretariat, which is also where the VPP mechanism is, and the technical review panel that oversees the grants to make sure that they're doing the right thing. And so that is obviously very far in every possible way from Laos. So in order to counteract that, the Global Fund sets up what's called local funding agents, and those are what their eyes and their ears on the ground. Now I say that they're located in Laos and regional because Laos does have an office for Swiss TPH is the local funding agent, and they do have an office in Vientiane, but their people move throughout the region. So they also work in Burma, Cambodia, and Vietnam. So there's not always a local funding agent in Laos. And then at the country level, each Global Fund grant recipient has to have a country coordinating mechanism and an oversight committee, which oversee the country coordinating mechanism is every key stakeholder is involved in the country coordinating mechanism, and the oversight committee is a much smaller, more nimble group that is involved with sort of day-to-day activities of the grants. And then they set up a primary recipient office, which in this case is at the Ministry of Health office. And then there are subrecipients that actually implement the programs. And so the subrecipients in Laos's case are CHAZ and SINPE and other groups that are doing AIDS, TB, and malaria work. And then there's the provinces, the districts, the health centers, and the village health volunteers. So this whole thing is difficult to explain and even more difficult to work within. So it's complicated. And this is not just for Laos, this is the way it is in every Global Fund country with some slight differences. So a little bit about public health supply chains, and this is the part I'm going to talk through kind of quickly, so just stop me if there's any questions. Supply chains consist of completely separate yet completely interdependent entities. So if you think about just within the Global Fund, if you think of that process as supply chain, think about how far away and how much has to happen before any information can get from the Global Fund Secretariat down to the village health level. So there's a ton of things that have to happen and have to happen well in that process, and that's just sort of one part of the overall supply chain of getting stuff into labs. They're extraordinarily complex, and you really have to have a well-coordinated supply chain, and any single complication can really disrupt the entire chain. There's a thing called the bullwhip effect, which you guys all know what bullwhips are, like the rodeo guy. Bullwhipping. So a disruption that starts off very small in one little place, the impact of it magnifies as it gets further and further away from wherever the disruption was. So that is well known in supply chain management theory and stuff, and it's something that we really have to consider in developing countries because there's obviously a lot of things that can go wrong at any point and the impact that that has throughout the whole rest of the chain. Supply chains in developing countries are often strained and weak. They mimic the overall health system of a country typically. So if a country doesn't have a well-established health system, they almost for sure won't have a well-established supply chain. And in order for supply chains to be really well operated, they need to be integrated into health systems programming. And I'll talk about what that means in a couple of slides. And research has shown that developing countries usually have two separate, distinct supply chains. The supply chain that gets commodities to the port of entry, and then from the port of entry to the actual patient. And it's that second part, from the port of entry to the end users, is what I looked at in my research. Ooh. So what that looks like in Laos, and these are in Laos, your eyes are not playing tricks with you. What that looks like in Laos is all goods come in through Vientiane, which is indicated in red. All goods usually come in by air. There's very poor road and rail infrastructure throughout the country, so almost everything comes in by air, which is kind of presents a whole other sort of logistical issues that we're not going to talk about here, but I'd be happy to afterwards if you're interested. And then goods and information go to regional warehouses, which are indicated in orange. There's 4 of them throughout the country. And then it goes down to the district level, and then to the health center level, and to the village level. So this is what I'm talking about when I mean in-country supply chain. So what's happening in that process is called the procurement and logistics cycle. So there's 4 main parts of this, and again, they're all interconnected and they all need to be working well in order for the whole system to be working well. But of course, we want to serve customers, which means we want to make sure that patients have access to the health commodities they both need and want when they need and want them. So that's that's obviously the main goal of any health program. Product selection is all about figuring out what people need. So it's looking at historical data, it's looking at current data, it's very, very data heavy. This product selection part is really what drives the entire thing, because if you don't have good data, you can't really do the rest of the process. Quantification and procurement is more of the forward-looking element of it. So it's taking all that data you have about historical and current use and figuring out what you need in the future and then actually putting the request in. So in Laos's case, it's submitting it to VPP. And then once you actually get the goods, then you actually have to receive them, you have to store them, you have to move them. It's all the typical logistics things that you think about. And if we do that well, then we ultimately serve customers. So it's a big chain, it's a big cycle that has to happen to meet the claim. Over all of this, of course, are sort of larger management issues such as organization, staffing, budget, all the things that are sort of working with the system as well and can have a direct impact on this cycle and really sort of determine how well it moves. In Laos, they've developed an arm of the Ministry of Health called the MSc-GH, which is the Medical Product Supply Center. And their role right now is to really be looking at the inventory management and logistics side of things and the quantification and procurement. So they are starting to build internal capacity to take care of some of these things. And as I said, this product selection category is so important. I'm actually writing a whole manuscript just about the data management and data collection part in Laos. I'm not going to be talking about it too much today because, frankly, it's a little nitty-gritty. The other stuff is sort of more welcoming on the surface. But it's extremely important, and I don't want you guys to think that I'm overlooking it. I'm not. It's getting a whole lot of attention. I'm just not going to be talking about it too much today. Yeah.
Do most of these activities happen at the national level? Or maybe you'll get into this, but what's the role of the Ministry of Health versus kind of the district level health centers? And is it more of a push or a pull system in terms of the Ministry of Health tells the districts or gives them a set amount of drugs, et cetera, or can the districts really request specific things?
So that's a great question. Laos has a decentralized healthcare system, so the provincial level and the national level work fairly well together. Once goods, information, finances move below the province level, the national level really doesn't have much control over what happens. So there's a lot of coordination issues that happen with that, and a lot of the issues in Laos's supply chain come from the fact that the national level program really doesn't know what's happening at the ground level, and because the data is either absent or it's of poor quality. There's been a lot of issues with just managing the programs in general, because if you don't know how many people in the village are getting malaria, how are you supposed to order treatment for them? So yeah, it's a huge problem. The decentralization is relatively new, and they did it not so much for HIV, malaria, and TB, but they did it for other health programs. It seemed to make sense to them at the time, but it's certainly an interesting problem. So we'll talk a little bit about that when we get to some of the results too. So I mentioned integrated supply chains. USAID operates the supply chain and procurement processes for the President's Malaria Initiative, PEPFAR, which is the U.S.'s HIV program. They're these huge, huge programs, and they've really had to go in and really create supply chains in a lot of the countries that they work in. They actually don't work in Laos, so all of the information that they've generated and all of the handbooks and guidelines are really useful in sort of the theoretical sense, but they don't actually have direct research and results from Laos. But they have identified these 6 characteristics of really well-integrated supply chains, including clarity of roles and responsibilities, agility, streamlined processes, visibility of information, trust and collaboration, and alignment of objectives. So we'll come back to these at the end after I go through my results, and we'll sort of see how Laos does. But it's important to keep in mind that those are sort of the big bucket items that are important in supply chain management. And they have conveniently come up with a framework for evaluating supply chains in developing countries, which is what I use to look at Laos's supply chain. So what did I do? I was based in Vientiane, which is the top arrow, which is the capital city. I spent 10 weeks working with in the WHO office in Vientiane, and I spent 1 week in Savannakhet province in the south, where I got to visit with provincial, district, and health center facilities. I did qualitative research that was based primarily on key informant interviews. I interviewed 39 participants and got 41 interviews. I interviewed 2 participants, once at the beginning of my research and once at the end. And again, I did document review, and I was able to do informal observations at all of the procurement meetings that were happening at the national level. I was there at a really exciting time. And so, oh my gosh, I forgot to tell you about the HIV test kit stock out. Sorry, I jumped past it to the bend. So part of what prompted this research was an HIV test kit stock out, that there are no test kits throughout the entire country. And I'll talk about why later. But that and the malaria outbreak in Adapa is what really prompted the WHO to identify supply chain research as a public health priority, which is what was the genesis of this project in general. Sorry, I think I slipped over that slide when I couldn't figure out the buzzer, or the clicker. So I was in Vientiane, working with the WHO, also traveled to Savannakhet, and used the USAID framework, and then I coded it in Vivo 9. So I'd be happy to, if you guys have questions about that, I can talk about it too. So this is just a quick overview of the participants that I interviewed, and I have quotes scattered throughout the results that have these classifications, so just so you know what I'm talking about. The global fund level includes anyone at the PR office or at the local funding agent office. I've interviewed people at both. The national level programs include anyone at the Ministry of Health, at SIMPE, at CHAS, or at the MPSC, the logistics arm. I also interviewed non-governmental agencies, so I interviewed people at the UN, UNAIDS, WHO, FHI, PSI, big NGOs that are working in the area. The provincial level, people at the provincial public health department, and then again another NGO that was working in the area, and then the district and health center levels were the employees of the public health system. So the results. There were 4 thematic areas that came out of my research: management and leadership of PSM activities, the procurement process and problems within that, human resources and capacity for supply chain management, and then also this data collection and reporting. And what was really interesting was that these themes came up in every level of the supply chain that I interviewed. I was not expecting that. I was expecting people to have varying issues and varying problems and challenges, but they all sort of consistently reported the same information, which was interesting in terms of consistency of data. And then another interesting thing is that everyone sort of acknowledged that there was a really poor system in place. There was not anyone who was like, this is great, we have everything we need. Everyone was very cognizant of the fact that it wasn't working well, and it could be working a lot better, and it needs to be working a lot better. So management and leadership. Accountability is a huge, huge problem. One of my participants said accountability is diluted when people can escape from responsibility, and they do. And this is not isolated to Laos. It's really problematic in a lot of countries, and the literature has confirmed that accountability within supply chain management is also an issue in Malawi and Uganda. There's very few examples of research that is similar to this, so when I was able to find it, it was nice to see corroboration to what I was finding. There's really no repercussions for people if they don't do what they're supposed to do. So there are some protocols in place, and if people don't follow them, there's nothing really that happens to them. Site management is really difficult. For malaria, there's over 6,000 sites that are supposed to report malaria information every month. And so you can imagine even just tracking down half of those would be difficult, let alone all of them. HIV is a little bit different. There's only 149 sites, so it's a little bit more frustrating that accountability isn't really built into those programs, but that said, it's not. Also really complicated is the relationship between the primary recipient office and the sub-recipient offices. The PRs really determine their work and define their work based on what the SRs give them, but the PRs are not empowered to hold the SRs accountable for anything. And the SRs really don't feel ownership over the Global Fund projects because they feel like they're just told what to do by the Global Fund. So it's this very interesting sort of both sides feel like they don't have power or control over what the other side's doing. Communication and coordination is huge, and particularly given the decentralized healthcare system, you can imagine how important communication and coordination is, and it's not really happening that well. And So when talking about the HIV test kit stockout, one of my participants said, you can make how can you make your program credible if you can't even offer someone an HIV test, which is really the crux of all HIV programming. If you can't test people, then how are you supposed to build a program around that? Coordination was cited 113 times in the data. It was the single most cited theme, which it was interesting. And having poor communication and coordination really causes unnecessary delays and frustrations in the process. And as we now know, it's such a long process to begin with that sort of any disruption in it is just immensely impactful throughout the whole chain. And there's a lot of issues about reporting, which I mentioned, and making requests and the misalignment of national guidelines. So I mentioned the HIV test kit stockout. And this is kind of directly correlated to the Prevention to Mother-to-Child Transmission campaign. So prevention of mother-to-child transmission for HIV is not a huge priority in Laos. Pregnant women are not an at-risk population for the most part. Like I said, it's really sex workers, many are sex-dependent, injectable drug users. And those are the three populations that the HIV program has rightly been focusing on. So UNICEF, one of their big campaigns worldwide is prevention of mother-child transmission. And so UNICEF came in and kind of circumvented the HIV program and campaigned to the Ministry of Health to get PMTCT testing implemented in hospitals. And so, who's going to say no to testing pregnant mothers and preventing babies getting HIV? It sounds like a great thing. And it should be done, but in a case like Laos, where there's limited resources and that's not a priority, it's just not something they were really building into the system. So the guidelines, the national guidelines date from 2007 for PMTCT. They're really bulky and really kind of unusable. People at every level I spoke to said they don't like them, they don't use them, they're not appropriate for the context of their setting. So they've been working for now 5 years to rearrange and revise these guidelines. UNICEF comes in, campaigns to the Minister of Health, gets approved, so then the Minister of Health says all hospital facilities will now test pregnant women, not once, but twice. Once in their first trimester, once in their third trimester, and we're going to prevent the spread of HIV through babies, through the birth of babies. So this is great, but CHAS is not made aware of this, and so they go along with their programming as though it's always been just the three most at-risk populations. They order for that many people, they predict that many people, they use all their forecasting data off that. So all of a sudden there's this huge drain on testing facilities and capabilities because you have really a huge population now that's looking to get tested, and they run out of test kits. So there are zero, when I was there were literally 0 test kits available in the entire country, and emergency procurement is not so easy to do. So they were sort of trying to figure out how they were going to get more test kits in the country. So it's a huge problem. And it's really, you can see that this coordination failure really has direct impacts because people can't get tested and people who are kind of voluntarily coming in aren't able to get the care that they need. So relationship management is also another really important theme that kept coming up again and again. And I wanted to sort of highlight 4 quotes that give you the range of things that I heard. Relationships were sort of defined as small as just the relationship between 2 people working together to the relationship between the Global Fund and the Ministry of Health. So that bigger, more systemic question is what I was more focused on, and that's what my data reflects more. So we start off with the Global Fund provides a model for how things should work, which is true. Then I know what the Global Fund wants, but it's very difficult to manage. So a little bit more angst in the quote. The Global Fund only wants to know about indicators and numbers. They're not focused on quality, which is a pretty significant thing to say. And then subrecipients are trying to back the Global Fund against a wall and force them to accept substandard reports and documents, which is hugely damning to the whole program and really sort of speaks to the relationship that Laos has had with the Global Fund and sort of the quality of information and the quality of the relationship that both parties have felt. So it's really tenuous. So, like I said, the relationship has been functional. The Global Fund has been able to do a lot of really good things in the country, but both sides really have these pretty grave frustrations that are now starting to really come to a head because the programs have been there long enough and there's been enough work in place that people are sort of settled into what's happening. One of the more challenging relationship management issues is the role of this local funding agent and what they're supposed to do in Laos. the Global Fund Secretariat in Geneva sees them as sort of an unbiased, almost auditing arm, frankly, of what's happening at the program level. And the country level program sees them as this great resource with all of this expertise and all of this knowledge that could really be helping the program create better proposals and do better documentation and do better reporting. So there's a big tension as to what the LFA is supposed to do, and they're often caught in the middle of a lot of disagreements, shall we say, about what happens going forward. I heard this a lot, the unrealistic expectations of the Global Fund, targets are too high, objectives are hard to meet. There's sort of a unanimous feeling amongst country-level people that what the Global Fund wants of them is just not really feasible. So it's sort of setting people up to fail in a way that they feel like it's setting them up to fail. Two other things that are causing pretty significant strain on the relationship is, I mentioned that the Global Fund is performance-based and they grade grants. Both the HIV and malaria grants were just downgraded to B1. And what that means is it limits the amount of money that the country is able to apply for. So automatically, you're reducing the pool of money that they can get each year. And then because Laos has just achieved lower middle income status, the Global Fund has a rule that if you, depending on your income status as a country, you have to contribute a certain amount to HIV, TB, and malaria programming, which is fair. But now Laos is required to commit a 20% co-contribution to Global Fund funding, and Global Fund funding is tied to whether or not they can produce that 20%. So it's 20% that the government was not prepared and not planning to spend. So they're now sort of scrambling. They have until the end of the year to figure out how they're going to come up with 20%. So party politics is not something I could have studied, but one of the participants told me that the complicated political system is an undercurrent to any and all activities. And that really, I can't overstate the role of party politics in the Lao health system, the Lao government, the Lao culture in general. It's completely unquantifiable, and people did not really want to talk about it, understandably, because everyone I was talking with was either directly employed with the Ministry of Health or worked directly with them. But it just is so powerful. And I can say sort of at minimum, it's a very complicated entwined system that really influences everything and has a direct influence on health. We just can't be entirely sure how that materializes. So procurement. So this VPP process, we talked a little bit about it in advance, but it's a really sort of bulky apparatus. People are required to submit yearly reports and yearly procurement plans. And this is not unusual. Most big programs will operate with a once-yearly procurement plan. But for Laos, this has proven to be very difficult to do and to do well. You need to have really concise data that has information about a lot of stuff. So you need to know exactly what you have in the country. You need to know how good, what quality, when they're expiring, prices, everything. You need to know kind of everything about every commodity you have. You need to know what's coming, and then you need to know what you need. So it's a lot of data, and forecasting is really hard for any organization. And particularly in the health sector, it's difficult. So it's complicated, and it demands a lot of data that people don't always have. But delays in approving these plans can really have catastrophic impacts. And in 2010, the commodities arrived literally a full year late because the Global Fund and the Ministry of Health couldn't agree on a procurement plan. So for a year, they were just burning through all of the stocks that they had. They were stocked out for the last couple of months of 2010 of malaria treatment and testing kits, and so it was a mess. There was a spike in malaria incidents because of this. It was very bad. It's not an agile process, and so it really can't react well to emergency procurement. So this HIV test kit example, Chaz could not procure test kits through VPP because it's not the way it works. So they had to go to outside sources. They actually had to get funding from an NGO and the WHO, and they provided emergency funding and emergency procurement, which involved then more coordination between all the different entities and obviously additional financing that's not always guaranteed. And it's really not sustainable in the long run. So, what happens if this VPP mechanism stops? Laos is really sort of will have the rug pulled out from under them. They don't have the capacity to do this now. So if VPP is not doing it, who's ultimately going to do it while Laos is ramping up their capacity? So one of the participants said, you can have a system that's running well, but if your ACTs do not come, then everything gets screwed up. And that's really sort of, I thought, a great way to sort of describe what happens if you can't get the goods that you need. Planning and receiving goods. Again, so procurement requires a 1-year plan. The Global Fund overall grant requirements are 5-year plans. And everyone I talked to said, we can't plan for 5 years. We don't know what's going to happen. Some of this is a little bit of resistance from the Laos level to do it, but it is, they haven't been able to do it effectively and haven't been able to do it well. Every year they have to change their plans, which is not completely uncommon, but it seems as though they've been having more issues than they should. Yes?
What is the requirement from the Global Fund for reporting each year?
So they have, every 6 months, they have to report on indicators. And then every year they have to report on procurement. And so the indicators, the 6-month indicators and the procurement indicators are a little bit different, but it's some of the same data. Excuse me. And then after 2 years of the grant, so they do funding for 5 years, but after 2 years you have to get reapproved for the last 3 years of the funding. Yeah. So, Amelia, you would know. I don't think any country has been denied the additional funding for 3 years, but
I think Ukraine.
The
Past years.
Oh, the Eastern European. Yeah. So Laos has never been denied the 3 additional years of funding, but it is possible. And the Global Fund now is really in flux. There's a lot of changes that are happening with the Global Fund. So it's possible that they'll become much more stringent on really denying people an additional 3 years, or really, significantly reducing what they get. But it's an interesting process. So there's 6 months reporting, yearly reporting, 2-year reporting. There's a lot of reporting, which is, again, another issue that people complained about. It's like they're constantly always just filling out reports. They're not able to actually implement. And then I'm not going to talk too much about the logistics part, but receiving goods is really complicated. It's really challenging for us because they're such a small country and they have such small demand. They're not really the priority of VPP. So they sort of get the dregs of what comes in, and they get shipments. They sort of trickle in. So if they place an order for 25,000 test kits, they might get 10,000, and then 3,000, and then 7,000, and then it just sort of, it's not efficient. Obviously, you ideally would want all of your stuff to come at the same time every year, and then you could sort of manage it and move it to where you need it, and that's not happening. They've also had examples, this happened when I was there, of receiving shipments that are either expired or about to expire. So it's a very real problem, and that happens in all health programs. It just seems to be happening a lot in Laos. So human resources and capacity. I touched on the MPSC. They were created by a government creed in 2009 to start doing a national level warehousing and logistics system. It took them 2 years to actually get a partner to work with them. So Chaz was actually their first partner. And their role is really kind of unclear because they're supposed to do the entire procurement cycle that I showed you. They're supposed to do that. That's in their mandate. They really are only doing the logistics part of it and sort of some of the forecasting and procurement, but their capacity's not really up to par yet. The concept is good in theory, but there really haven't been outcomes to really show whether or not it's positive. And there's serious concerns about whether the MPSC can handle just one line of goods for HIV, let alone the entire portfolio that the Ministry of Health has. So there's some question as to whether or not this is the best way to move forward. One of my participants said the MPSC has not been able to show that they are able to procure, and if they could, it would not be done with innovation. So this concern really speaks to they would just sort of get the fair level of what was required for the country. They wouldn't get what people actually want and what people actually would use. So with training, it's interesting because training is something that we talk a lot about in the classroom. And it was interesting to see how that training sort of transpires in the field. Procurement training has been limited, although when you ask people about how they've been trained, they'll say, oh, I haven't gotten any procurement training. And then they'll sort of rattle off 4 or 5 things that they've done, and they got sent to Bangkok to do this, and Cambodia to do this. And so it was sort of difficult to gauge how much training has actually happened. But it is clear that in terms of, particularly with like the numbers and the data part of things, it's a lot of learning by doing and a lot of just ad hoc kind of making it up as you go. So it's not the most effective way by any means to be doing research and reporting. And there's a lot of resistance from people in procurement positions that they don't really want to be doing this work. And this actually was not unique to just one participant. They said, we're all doctors, we're not trained in procurement, so we didn't come in to do data analysis and reporting, we don't want to be doing this, but we're put in these positions. And so it was interesting to sort of see the roles and the responsibilities that people had and whether or not they wanted them. One thing about procurement positions, and this is certainly an example of the government's influence over the health system, is that they tend to be paid better. And particularly positions that work with the Global Fund are certainly higher paid than those just through the traditional Ministry of Health outlets. So people who are sort of managing these programs tend to be assigned there by ministers or have some connections to party politics. So it's a very clear example of how the government has influence. And some of those people who were assigned to be in those positions were the ones who were most vocal about not wanting to be in those positions. So it was an interesting dynamic. So I'm just going to give you a little bit of a preview of what I found with data collection and reporting, a little teaser. So one of my participants said, without good data analysis and collection, you build your whole program on sand. So you build a really unstable foundation. Like I said, it requires access to timely and accurate data. Supply chains depend on it, and it's not available currently in Laos. And the data that is available is often not analyzed and cleaned. It's just sort of passed up the chain, and so the PR office ends up with all of these mismatched and misaligned spreadsheets and documents, and it's really confusing for them to try to figure out what's right, what's wrong, what needs to be done. Without data and without analysis, country programs are always going to be operating in crisis mode. They're always going to be reacting to things. So they're going to be reacting to shortages, to test kit stockouts, to all these other problems. They're not going to be able to really proactively plan and work through problems and figure out how they're going to solve them before they happen. Like I said, reports are usually absent or late. There's a really intricate reporting calendar that every institution and facility is supposed to follow. It doesn't happen. So, and there's no accountability to hold people to those schedules. And receiving reports was cited at every level of the supply chain. So even the health centers at almost the bottom, they could not get reports from village health volunteers, and it just continued all the way up the chain. And the forms that are required are really difficult to fill out, and often at the health center and village health volunteer levels, there's serious literacy and just sort of capability issues with reporting. And they're really challenging, and every program has a different form, and every aid organization that's in Laos has different reporting mechanisms and different indicators that they need. So it's just a lot of information, and it's a big tax on people's time. So it's often the first thing to go when they have all the other things going on. But if we can improve these data collection and analysis mechanisms, then we can really improve the overall supply chain. So it's really important to focus on them and think about ways to make them better and more streamlined. So we found these themes: data collection and reporting, inadequate management and leadership, procurement challenges, limited human resources and capacity. And if you recall, these are the 6 integrated supply chain themes. So I paired them up, and we can see that visibility of information is obviously lacking, even just through the little preview I gave you of the results. I'm sure that's obvious. Streamlined processes are not in place. Trust and collaboration is not in place. Alignment of objectives is also quite weak. The VPP mechanism is not agile, and there's certainly not a clarity of roles and responsibilities. So we can see that Laos is pretty far from what would be an ideal integrated supply chain. Does anyone have any questions so far? So there are some limitations to this research. It was only done in the Laotian context, and I'm not entirely sure how much of it can be extrapolated to other countries because supply chains are so specific to the context. I only was able to do research in 2 of 17 provinces, so ideally I would have been able to go to every province and really see what was happening at the ground level everywhere. I purposefully limited the commodities I looked at to HIV test kits, malaria treatment, malaria testing, and bed nets. So ideally, I would have been able to look at all commodities within both health programs. And ideally, I would have been able to supplement this research with quantitative work, actually looking at what the real data, like going into warehouses and seeing what was actually on the shelves of places and being able to compare it to A, what was reported, B, what was forecasted, and C, what was planned for. So that would have been really great to be able to do that. And I wasn't able to look at a lot of these issues that I found and compare them to other countries in the region or other Global Fund countries to see if there were similar problems throughout. Some of the literature I found indicated that similar issues were happening, but obviously it's not anything that I could have researched myself. So that was a bit disappointing for me. But there are some suggestions, and they're actually tangible solutions, which is exciting. Developing a supply chain team for each program would really help a lot of the issues, because people who are working in supply chain management now are doing it in tandem with a ton of other activities. So it really involves people looking at this and thinking about this and focusing on it full time. So if we could develop a team of people that can coordinate not only at the national level, the Global Fund level, but also down to the district health centers, district level, the health center level, that would be great. Just if someone could literally focus on that and do that, that would help immensely. And it would also just help to have people accountable for this work, have it be their sole responsibility, and see whether or not it's working or not working and how things can be improved. Strengthening, those are not all one in my original thing. They're all number one. Strengthen the capacity and focus of MPSC is also really important. The government has decided that this is the way they're going to move forward. They want the government to manage supply chain and procurement for the country. There's some question as to whether or not moving forward with the government system is best. Research has shown and anecdotal evidence has shown from the people that I interviewed that working within the private sector is much more efficient. That's not what the government wants to do, so suggesting that is not even a valid point because they will just totally disregard it. So because they've decided to go forward with the MPSC, they really need to put the resources into it and really sort of work to build that up to what it really needs to be, which hasn't been their priorities yet. And then streamline program-specific and national guidelines is hugely important. We can't have another thing happen like with the PNTCT guidelines. That was just disastrous. So we need to make sure that guidelines are usable, and you have sort of your ideal, and if you can't do the ideal, then what's your second choice option, what's your third choice option, and that really needs to be established so that people at the district and at the health center levels feel as though the guidelines are actually approachable and usable for them in their contexts. So the next steps, like I said, there are really tangible steps that can be taken, and the government is really willing to put emphasis and focus on supply chain management, so that's good. And right now, Laos has the financial and human resources available to them through the Global Fund to really kind of start building this capacity and working to make really important changes. So ultimately, ideally, this entire process in the not-so-distant future could be turned over to Laos. At this time, they don't have the capacity, but if they utilize what's available to them and really move forward, they could, for sure. And then an exciting part that I don't really have anything to do with is my mentor, Dr. Tong, is working with the Ministry of Health in Laos to redo their entire health system strategy. So there's a chance that this work that I've done on just a very small part of the supply chain could ultimately get folded into the larger health strategy, which would be really great. But that's, again, not really up to me. So just a few acknowledgements. Dr. Tong and Professor Miller are on my committee here, and then Dr. Dominique Ricard was my supervisor in Laos, and he is also on my committee. They were great. The entire WHO in Laos was phenomenal. They welcomed me very warmly, as did the Ministry of Health. I was sort of waiting for doors to get slammed in my face and phone calls yelling at me to start happening, and it never did. People were very willing to talk to me and very open to discussing these issues, which was surprisingly great. Lisa McKean and Sarah Martin here at DGHI were very helpful in setting up my whole fieldwork project, and funding came from DGHI and thesis. And of course, my family, my husband and my mom came, and my roommates who got to see me pulling my hair out. So thanks to you all. And I'd be happy to take any questions. And this is the central warehouse in Laos, in Vientiane.